A professor of pediatric rheumatology at Shahid Beheshti University at Tehran, Iran. And we are very happy to have you here today. I will just go through the usual introduction of the speaker and the moderator, if you let me. And then Dr. Shiari will talk a little bit about the topic of today's talk. And then, if you may, we will start the speech. Thank you very much. Is it okay, Dr. Kasapcopur?
Yes.
Thank you. Thank you very much. Hi, Dr. Shiari. It's such an honor to have you here today. Sorry for the inconvenience.
Hi to everybody, and my warm hello to Professor Kasapcopur. We are very honored to have you here today. To all participants, that we are talking about the Pifapa today, the syndrome of periodic fever after stomatitis, pharyngitis, and cervical lymphadenitis is the most common cause of periodic fever in childhood. And the current pharmacological treatment, including steroids, colchicine, and many other medication, which has not been proved so far. So is using and tonsillectomy maybe the last way for some of the elective patients. Now today, we have this chance to have Professor Kasapcopur. Professor is pediatrician, a pediatric rheumatologist, professor in pediatric Istanbul University, as far I know, and he's also the chairman of the pediatric rheumatology in Istanbul.
Yes.
And he has more than 800 peer review paper, and also many, more than, as far I know, more than 18, I guess, book chapters about the pediatrics and pediatric rheumatology, which has been published in Turkish. So we have the chance to have you today, and we are eagerly ready to listening to your presentation.
Thank you very much for kind presentation to me. I am very honored this lesson. Now I am south part of Turkey in Adana for pediatric congress. I want to introduce to you PFAPA syndrome. Yes.
Okay.
Thank you very much for your kind invitation.
Thank you very much, dear Professor.
Firstly, I want to present one patients, 3 years old female patients, previously healthy boy, postnatal period uneventful, breastfeeding until the age of 9 months, new onset of recurrent fever lasting for 3 or 4 days, repeating once per month. Fever accompanied by cervical lymphodenopathy, oral after stomatitis, and cryptic tonsillitis. In laboratory examination, increased acute phase markers at attacks, rapid streptococcal test and nasopharyngeal SWAT culture are negative. Duration of attacks 3 or 5 days despite the antibiotics and antipyretics. Workup the first day, we work up for the immune deficiency, no pathological findings, and secondly, we investigated any autoinflammatory disease. Our patients had had not a rash and any musculoskeletal involvement. Laboratory parameters in normal limits during the attack-free period. We examined our patients in attack period. She had a fever and cervical lymphodenopathy, cryptic tonsillitis, oral after stomatitis, increased acute phase markers. We diagnosed PFAPA syndrome. Firstly, both of them, treatment and diagnosis, 2 milligram per kilogram methylprednisolone, single dose intramuscular route. Fever decreased in the 4 hours. Control examination after another day. No signs of cryptic tonsillitis. The patient has been referred to otolaryngologist for consideration of adenotonsillectomy. Frequency of attacks increased every week despite the good response to the corticosteroid. First side effects of corticosteroid using in Pifapa syndrome increase the attack period. Tonsillectomy has been performed at the age of 35 months. The patient is attack-free during the last 5 years. Yes, dear colleagues, Pifapa syndrome is very important problem, but unsolved problem in general pediatric area. Pifapa syndrome is periodic fever, after stomatitis, pharyngitis, and cervical lymphodenopathy. This is autoinflammatory condition commonly seen in childhood, unproven genetic inheritance. But we have families, father or mother, and children with Pifapa syndrome, characterized by recurrent fever. Together with familial Mediterranean fever, the most common recurrent fever in Turkey should be considered a differential diagnosis of patients under the age of 5 with complaints of recurrent fever. As said before, recurrent attacks of fever with sudden onset, another after stomatitis, pharyngitis, and cervical lymphodenopathy. Patients have mental and motor development appropriate for the age, most common among patients under the 5 years old. Fever in clinical features, fever with sudden onset, generally unresponsive to antibiotics and antipyretics, mostly 39 degrees. Patient in fever period, patient in a good general condition despite the high fever. Fever is spontaneously decreasing 3 or 5 days. Fever decreasing 3 or 4 hours after the administration of single dose of corticosteroid. Fever remains in normal limits till the next disease attacks. Oral findings, combined fever, are typical and pathognomonic. After stomatitis could be complicated by the moniliasis in small children. In general, after stomatitis resolved together with fever, herpetic gingivostomatitis should be considered in the differential diagnosis. Our patients as you've seen, our patients in after stomatitis and cryptic tonsillitis and other findings. Our the families of patients should be diary for fever and another attacks. And bilateral cervical lymphodenopathy is seen during the attack. Generally, lymphodenopathy appears submandibular, extending during the cervical region bilaterally. Expect for cervical lesion lymphodenopathy other parts of body. But in Pifapa syndrome, abdominal pain is related to mesenteric lymphadenitis. Hyper-IgD syndrome should be considered differential diagnosis of lymphodenopathy. As you see, our patients in after stomatitis, cervical lymphodenopathy, and other clinical findings. Cryptic tonsillitis is one of the most prevalent findings. Tonsils are generally hypertrophic. Prominent pharyngitis could be seen. Nasopharyngeal swab culture and fast streptococcal tests are negative. Tonsillitis is unresponsive to antibiotics, but promptly responsive to corticosteroid. As you see, our patients with cryptic tonsillitis and other patients, we discussed and we examined Pifapa syndrome in childhood, a lot of publication. Firstly, we have our manuscript is Pifapa syndrome, signal center experience. We published this study in Turkish Archives of Pediatrics. Our objective, the purpose of this study is to share our experience about clinical findings and natural course and treatment response rate of a large cohort of patients with Pifapa syndrome. The medical records of our patients who were diagnosed Pifapa syndrome between January and May. At our clinic, we reviewed retrospectively. A total 607 patients with Pifapa syndrome were included in the study. The median age at disease onset, age diagnosis, 18 and 36 months respectively. Duration of attacks was 3 days and median interval episode 20 days. In total, patients who did not undergo tonsillectomy and adenoidectomy episode ceased during the follow-up. Among these patients, the median age last attacks and median disease duration were 66 and 40 months. Family history of Pifapa syndrome, tonsillectomy and FMF was detected in 30% of our patients, respectively. Most common clinical findings in our cohort: fever, pharyngitis, after stomatitis, and cervical lymphodenopathy. No difference according to gender expect for cervical lymphodenopathy being higher in males. And another, our patient, 95% of our patients who were given steroids during attacks were responsive. Constant treatment, surprisingly, constant treatment was effective of 64 of patients. Tonsillectomy was effective in 213 of patients. Did you see our cohort in tables? And as you've seen, firstly, another big problem in Pifapa syndrome, another big problem is classification of Pifapa syndrome in childhood. First, the classification criteria was described by Dr. Marshall: onset before the age of 5, recurrent attacks, presence, additional reported symptoms, increased acute phase markers during the attacks, good general condition between attacks, exclusion of cyclic neutropenia, and another autoinflammatory condition, exclusion of the immune deficiency, infection, and autoimmune disease. Newly proposed Pifapa criteria same previously diagnostic criteria. This criteria was described by Pinto. Periodic fever during last 6 months and another attacks of pharyngitis, cervical adenitis, oral aft, exclusion of other periodic fevers, exclusion of immune deficiency, infection, and cyclic neutropenia. Disease onset before the age of 6, complete remission between the attacks, and normal growth of patient. Our study groups, this performance recently proposed PFAPA syndrome in endemic for familial Mediterranean fever patients altogether. To evaluate of the performance recently proposed PFAPA criteria in endemic FMF, our study group composed with Pifapa syndrome, FMF, and juvenile idiopathic arthritis patients. In conclusion, recently proposed Pifapa criteria have high sensitivity but low specificity in regions endemics for FMF. In conclusion, recently PFAPA criteria have satisfactory sensitivity, specificity is under expectation. If they need more specific criteria, there is a need prospective study with a higher number of patients. I am sorry. Another study in this matter, the role of Mediterranean fever gene variants in patients with Pifapa syndrome. Pifapa syndrome, a very catastrophic diagnosis in our country with FMF. We diagnosed according to Pifapa syndrome and performed with gene analysis with Pifapa children. The aim of the study was to evaluate the frequency of BIF gene mutation among Pifapa patients and to explore its effect on clinical presentation. Did you see our study results? Exon 2, exon 3, very important mutation in Pifapa syndrome. This exon 3 mutation must be investigated on etiopathogenesis of Pifapa syndrome, and exon 10, another mutation. Exon 10 mutation is very important for FMF. Similarly, Pifapa syndrome. About 40% of patients had no mutation in Pifapa syndrome. Most common mutation is M694B and another mutation. This, as you've seen, our another, as you've seen, our another in disease with variants in exonon. Exonon, very important mutation in FMF. Without exon 10 mutation, with exon 10 mutation, and with MEF-V gene variants and another duration, Pifapa episode duration is very long. Another drugs. Duration is of attacks were shorter. Age at disease onset was higher in patients with exon 10 mutation, comparing the non-exon 10 mutation, those without any patient. Is there modifying effects of MIF gene mutations on phenotype of patient who are carrier of mutation? Similarly, in another disease, for example, MEF gene is a protective effect for tuberculosis, another disease. In our study, there was no difference in response to colchicine treatment between those with and without MEF-V gene mutation. Pifapa criteria has a better ability to make a differential diagnosis of FMF and Pifapa, higher sensitivity and specificity. This is the first study evaluating colchicine response in Pifapa patients with newly proposed Pifapa criteria. Another more discussion in treatment of Pifapa syndrome. Disease attacks in Pifapa have no response to antibiotics and antipyretics. Studies evaluating the effects of cimetidine to prove their efficiency. Attacks show prompt response to single dose of corticosteroids, what is expected as one of disease criteria. Another study published in Journal of Pediatrics 4 years ago, Pifapa syndrome in a population endemic familial Mediterranean fever. As you see, our cohort, 359 patients, and similar to clinical findings, cryptic tonsillitis, autostomatitis, and other clinical findings. But familial Mediterranean fever gene is very important in Pifapa disease. In this study, we reviewed the medical records of patients with Pifapa syndrome to investigate the clinical course, treatment response, and association with gene mutation. In conclusion, familial Mediterranean fever should be considered in patients with Pifapa don't respond to adenotonsillectomy. And tonsillectomy represents the only permanent treatment solution. This is our study, is submitted to another journal. Tonsillectomy, only permanent treatment solution. Most of patients shows good response to tonsillectomy with resolution of symptoms and cessation of disease attacks. Previous study reported than 90%. Our studies shows the tonsillectomy has effective treatment modality. Another treatment modality is colchicine. Colchicine is most important drug for Pifapa syndrome. As our patients have MIF gene mutation, colchicine treatment is discussed with family. As you see, our operation materials in our patients with Pifapa syndrome, as you see, adenoid and tonsillitis. And another study, the presence of BAF mutation increase response to colchicine. However, it does not influence the response to corticosteroid nor to tonsillectomy. Our review published in Rheumatology International, most important issue in general pediatrics and pediatric rheumatology, familial Mediterranean fever and Pifapa syndrome differential diagnosis. Two clinical syndrome shared similar features, but two diseases have main difference. First, the diagnostic algorithm. First, the important clinical findings is cervical lymphodenopathy, pharyngitis, autostomatitis. These clinical findings in Pifapa syndrome, and arthritis, arthralgia, erysipelas like erythema, abdominal pain, very important clinical findings for Pifapa syndrome. And another study on this subject, independent risk factor in Pifapa syndrome, 466 patients fulfilling Marshall Pifapa criteria were included. Spontaneous resolution of Pifapa syndrome in the first 2 years of the disease onset has been evaluated. Regression analysis has been performed for patients with at least 4 years of follow-up. As you've seen, our logistic regression models and univariate and multivariate analysis in this table, our most important criteria is mean disease onset, family history of PFAPA syndrome, and headache. Late disease onset, family history of Pifapa syndrome, lag of headache are associated with the cessation of the attacks in the first 4 years after the disease onset. And as a conclusion, late disease onset, family history of Pifapa syndrome, lag of headache are associated with the cessation of the attacks in the 4 years after the disease onset. Therefore, patients before mentioned characteristics should be followed up with symptomatic treatments, while those without such features for the early tonsillectomy. In conclusion, Pifapa syndrome should be considered in all children younger than 6 with history of recurrent fever. For the search diagnosis, cryptic tonsillitis should be noted and the infection should be excluded. In region like Turkey and Iran, with high frequency of MEF gene carriers, the phenotype could be more severe. Treatment of options are controversial. Thank you very much for your attention and thank you very much for your kind invitation. I am sorry my lateness.
Oh no, thank you. Thank you very much. It was such an honor to have you here today. And in fact, it was my fault. I should have double checked with you. I'm so sorry. And if you let me, just before Dr. Shiari starts, in fact, asking the questions, I should just do this because we usually do this as a routine. We introduce the moderator and the speaker. And because the session started late, we went straight to the lecture. So I will give a brief introduction about our dear speaker and our dear moderator of today's session. In fact, Professor Ozgur Kasapcopur is a professor in pediatrics at Istanbul University, Cerrahpaşa, a medical faculty, Department of Pediatrics, and he's currently head of pediatric rheumatology. He serves as the chairman of Institutional Review Board and Clinical Research Ethical Committee of Cerrahpaşa Medical Faculty. Professor Kasapcopur received his undergraduate education in medicine at Istanbul University, Cerrahpaşa Medical Faculty, and completed there both his residency and fellowship in the Department of Pediatrics. Professor Kasapcopur is a member of the Pediatric Rheumatology European Society or Press, Pediatric Rheumatology International Trials Organization or PRINTO, Turkish Pediatric Associations, and the Turkish National Society of Pediatric Rheumatology. Professor Kasapcopur's research interests include vaccine response, cytokine pathway, and medical ethics with clinical emphasis on juvenile idiopathic arthritis, FMF, autoinflammatory diseases, and juvenile systemic lupus erythematosus, dermatomyositis, and scleroderma. Professor Kasapcopur has published 58 book chapters in Turkish medical textbooks and more than 266 original peer-reviewed articles and case reports in medical journals. He has more than 6,000 citations in Web of Science. That's impressive. And the moderator of today's session is Dr. Reza Shiari from Iran. Dr. Shiari is a professor of pediatric rheumatology at Şehit Beheshti University of Medical Sciences, Department of Pediatrics, and is currently the head of the Department of Pediatric Rheumatology in Şehit Beheshti University. He serves as the chairman of Iranian Board of Pediatric Rheumatology at Ministry of Health and Science in Iran. And he received his MD in medicine and finished his residency in Department of Pediatrics at Şehit Beheshti University of Medical Sciences. He completed his PhD and postdoctoral fellowship at Hokkaido University School of Medicine in Japan. Professor Shiari is a member of the Pediatric Rheumatology European Society or Press, Pediatric Rheumatology International Trials Organization or PRINTO, Iranian Pediatric Association, and Pediatric Rheumatology Society of Iran or PRSI. Professor Shiari's interests include medical ethics with clinical emphasis on juvenile idiopathic arthritis and juvenile dermatomyositis and joint hypermobility. I'm very honored to have this number of audience here today, and I'm so sorry for keeping you all wait. And so we will go to the questions, and Dr. Sherry, will you please start the session and ask the questions? Thank you very much.
Thank you very much, Gosar. Thank you very much, Dr. Asnakshari. I really appreciate Professor Kasapcopur, very interesting presentation. We learned a lot. And I'm really happy because we have many similarity between Turkish and Iranian Pifapa syndrome because of the MEFG. So I have some question. I will be appreciate if you kindly respond to the questions. First of all is about the age of resolving the disease. Most of us thinking that the Pifapa syndrome resolves in adolescence, but the new coming evidence shows that we have the Pifapa even in adulthood. So what do you think about it? Is there any relation between the genes or maybe some relation to overlap with some disease?
Yes, I agree with you. Pifapa syndrome is not resolved question in medicine. Our colleagues in adult rheumatology have a Pifapa syndrome patients, a little part of patients, but all patients resolve on adolescence. Their clinical findings result in adolescent period, but this question is not a solved problem in general medicine.
Yeah. Thank you. And okay, thank you. Another question is about the role of allergy in Pifapa syndrome. So do you suggest some hypoallergen diet to your patients who are suffering from Pifapa syndrome? Do you really believe in that or not?
Yes, I don't have any knowledge this allergic relation between Pifapa syndrome and allergy. We did not use it treatment in our patient. We did not use zinc. I don't know, but another center in the world, they are suggested to patients allergic treatment. I have read in a manuscript, but I don't have any using this treatment modalities.
Okay, thank you. And the question is about using colchicine. So as you mentioned, there is some relation between Pifapa and maybe MEFG gene. So do you recommend using colchicine as a one of the medication for control or as a prophylaxis treatment for the patients who are suffering from Pifapa?
Yes, we are using only colchicine, but these patients have any MIF-gen mutation, exon 10, but recurring attacks, very high number, we are using colchicine only. We did not use cimetidine or another drugs. We did not use. We are not using.
Okay, Professor Salezade asked the question. You explained about the mutation of MEFG gene in children who are suffering from Pifapa syndrome. Professor Salezade asked that what is your normal and healthy people MEFG gene mutation?
Repeat again.
Professor Salezade asked that what is your MEFG normal mutation in your normal
mutation?
population?
Yes, I understand.
So what's your MEFG?
We are not using colchicine. MIF-gen mutation is normal in PFAPA syndrome. We did not using colchicine.
No, the question is about that in your normal population. Do you have
Normal?
any, in your normal population, in your
In normal
normal
population, yes.
do you have any MEFE gene mutation?
No.
I mean, for example, E148Q mutation, we have in normal population a lot. But
Yes.
what's your normal population mutation? Do you have any information about it?
Yes. Yes.
Dr. Salazar, if you can, Dr. Salazar, if you can ask the question by yourself. I guess you need to ask by yourself.
Yes.
Yeah, I muted him.
Hi, Dr. Ozgur. Thank you very much for a wonderful presentation. My question is, what is the normal population in Turkey who have these MEF mutations?
I did not heard you. Please repeat.
Okay.
I am now in meeting.
Yeah. You are. I think you are in outdoor.
Please write your
Yeah.
question.
What is the normal? What is the MEF mutations in normal
is the MEF
population
mutation?
of? Yes. What is the MEF mutations in normal population of Turkey?
12.
And which mutation?
Yes, MIF-gen mutation frequency is very higher in normal Turkish population. Approximately 20%. 20% in very higher MIF-gen mutation carrier state in normal Turkish population.
Okay, thank you. Dear Professor, the colleagues asked that which kind of medication do you suggest as a prophylactic treatment for Pifapa?
Only we are using only colchicine prophylactic treatment. We did not use. We are not using another drugs.
And the dosage that you are using is as the same as FMF.
Yes, same dosage with FMF. Same dosage with FMF.
Okay, thank you very much.
You're welcome.
I know you are busy.
In chat part of my friend, what's a question? I see. Do you have any experience on PFAPA in adult patients? No, I don't have any experience. I am a pediatric rheumatologist. I don't have adult patients. What treatment do you suggest? In my opinion, tonsil adenoidectomy best treatment modality in PFAPA syndrome. I suggest all patients in adult or pediatric, I suggest tonsil adenoidectomy. But unresponsive tonsil adenoidectomy, we can use colchicine treatment.
Okay. Thank you very much. Dear Professor, in Turkish also we have also in Iran, we have many patients, children who are suffering from periodic aphthous fever, and they are not dramatically response to prednisolone. And by age, we understand that they are suffering from Beckett's disease. We have the overlap of Beckett's with also Pifapa, I guess. And we know many of children who we mark them as a Pifapa. In adulthood, they are maybe progress and to be as a Beckett's disease. Yes. So do you have any recommendation how we can differentiate this kind of disease? How can we differentiate when we should be suspect to Beckett in case of Pifapa?
Yes, yes. Beckett disease and Pifapa disease, firstly, the differential diagnosis is very important, hyper-IgD syndrome. We diagnose firstly Pifapa syndrome, and secondly diagnosis unresponsive to tonsil adenoidectomy. Second diagnosis is hyper-IgD syndrome. Another disease with compatible with PFAPA syndrome, Behçet disease. Behçet disease is a very important disease with differential diagnosis of PFAPA syndrome. PFAPA syndrome and Behçet disease are similar findings. In growing up, the Pifapa syndrome were diagnosed to Behçet syndrome. Firstly, we will investigate the relationship between the Pifapa syndrome and Behçet disease. Very important investigation area in pediatric rheumatology and adult rheumatology.
Thank you very much. I mean, for Pifapa syndrome, do you recommend to investigate HLA typing for all the patients, or just for the patients who are resistant to prednisolone? Do you recommend HLA typing for B5 or B15 line?
We did not investigate HLA typing in our Pifapa syndrome, but thank you so much for your recommendation. Firstly, we will investigate HLA situation in Pifapa patients. Very most important investigation area in Pifapa syndrome. Thank you so much for your recommendation.
I know you are busy in meeting, and we don't know how long do we have this chance to have still you in the webinar. If the colleagues any who have questions, please raise the hand. One of the colleagues asked about the role of vitamin D deficiency and the role.
Okay, I have one question to you. What do you think about vitamin D deficiency? Vitamin D deficiency, very important clinical situation in COVID-19, in other drugs, in diabetes. A lot of study. Vitamin D is, I don't know. What is your opinion? Vitamin D deficiency, very high persons in healthy children, very important.
I remember when I was in Singapore almost 10 years ago, and I met all the posters. Almost 70 or 80% of the posters belongs to vitamin D deficiency and SLE. Vitamin D deficiency and RA.
I agree with you. Vitamin D deficiency, very, I don't know.
we just recommend to use that. That's it.
Yes, everything must using the vitamin D.
Yeah.
Every children must use normal vitamin D.
Yeah.
Like in infancy. Like in infancy.
Yeah. Okay. Thank you very much. And the last question, Dr. Salazade asked the relation between breast milk and Pifapa syndrome. Yeah.
Breast milk. Breast milk is very important. I believe epigenetic factors very important in all inflammatory disease. Epigenetic factors, firstly in childhood, breast milk. We have 25 years ago, breast milk patient in GIA patients. In GIA patients, breast milk using very important. But we did not any knowledge in Pifapa syndrome and breast milk. This topic will investigate in our patients. I didn't know any relation. I don't have any.
No evidence, you mean?
Yes, no evidence.
Yeah, thank you very much.
Most important issue in pediatric rheumatology, breast milk.
Yeah, thank you very much. Thank you, Dr. Professor Kasapcopur.
Surname is very difficult.
The name is very difficult.
Kasapcopur. Very difficult.
So sorry.
Ozgur. My name is Ozgur.
Yeah,
My first name is Ozgur. Is simple.
yeah. The Professor Ozgur. Yeah, Professor Ozgur is better, I guess. Professor Ozgur, thank you very much for your time, and we really learned
You're
a lot.
welcome. I am sorry my lateness. I am sorry. Now I am in National Pediatric Congress in Adana, south part of Turkey.
Yeah.
Adana. I am sorry.
You're welcome. Dr. Asna Şeri.
Yeah. Thank you very much, Dr. Kasapcopur, for participating in today's conference, although you had so much to do there and you were so busy. I'm sorry for bothering you, but we were so honored for having you today and for this outstanding presentation. We definitely hope that we can have future collaborations. Is there anything else that you want to add, Dr. Kasapcopur?
Thank you so much. Thank you very much for your brother and sister from Iran. Iran is a very important country for me. In small children, I read Samet Behrengi history. Samet Behrengi textbook. My son and my all children, my first present to children, Samet Behrengi child books and a little black fish. Very important,
little black fish.
A little black fish.
That's a famous
very
story.
important. 1 minute.
Black is
Very
small.
important tale book in our country.
We also enjoy reading many authors of, in fact, Turkish literature, like Aziz Nesin, I think.
Yes,
it's very
Aziz
famous
Nesin.
here. Yes, and we like them really. Thank you very much. It was really nice having you here, and I hope we can meet soon. Oh God, that's so nice. They're so cute, so cute. It's adorable. Thank you very much. Thanks.
You're welcome.
Okay.
Thank you,
You're welcome.
Professor. Thank you very much. Have a
Thank you,
nice
and
day.
Dr.
I'm sorry.
Shai. No,
I am
it's totally
sorry.
okay. It was my fault.
Why late?
No, it was totally okay. Thank you very much. And Dr. Shai, thank you very much for being the great moderator of this fantastic session. Thank you.
You're welcome. Thank you. Thank you.
You're welcome. And well, this session was the last session of the solar year 1400. The Iranian New Year will arrive in 9 days, and we are all thrilled. Our next and probably last session for this course will be held on April 8th, after the Nowruz holiday, which is the spring holiday of Iran. The speaker of the last session will be Professor Angelo Ravelli from Italy, and he will be talking about the challenges of diagnosing MAS at presentation of autoinflammatory disorders. I am very grateful for participation of all you academics in this session of How I Treat Autoinflammatory Disorders course. I hope you have had an enjoyable time, and sorry for the inconvenience of starting the session late. We will share the posters later with the participants, and then we can send the certificates. The posters can be found on the session's webpage after a few days, and I also send the posters to the participants. As I mentioned before, the certificates are approved and validated by Asia Pacific League of Associations for Rheumatology, or APLAR, Pediatric Rheumatology Society of Iran, Iranian Rheumatology Association, and Tehran University of Medical Sciences. We will be very grateful if you can fill in the feedback forms as well that we shared in the chat forum. Thank you very much and have a great day.
Thank you, Professor. Have a nice day. Bye.
Goodbye. Goodbye all. Goodbye, Dr. Shai.
Goodbye, everyone.